I'm very pleased to announce Dr. Monique J. Brown, who is an assistant professor in the Arnold School of Public Health at the University of South Carolina in the US. So, welcome and take it away, Dr. Brown.
Thank you so much. Thank you, everyone, for having given us the opportunity to present this work on childhood sexual trauma and opioid use among older adults living with HIV. Once again, I'm Monique Brown, and I'm in the Department of Epidemiology and Biostatistics at the University of South Carolina. So first, I'll give a background on the topic, and then I'll give the rationale and aim for the study, the methods, what we did, results, what we found, and we'll have a session or a section for discussion and implications. So as we know, due to effective treatment, people are living longer and healthier lives with HIV. So in the US in 2018, approximately half of people living in the US with diagnosed HIV were 50 and older. In 2019, 1 in 4 new HIV diagnoses were among people aged 45 and older. When we think about older adults living with HIV globally, in 2016, 8 in 10 of older adults living with HIV globally were in low and middle income countries. UNAIDS estimates that the number of people aged 50 years or older with HIV globally increased from 5.4 million in 2015 to around 8.1 million in 2020. So we can see that the prevalence of HIV is increasing not only in the US, but also at the global level. And there are some prevention challenges that we have to consider with respect to older adults living with HIV. So older adults and their providers are less likely to discuss sexual and drug use behaviors. And really, research has shown that healthcare providers are less likely to initiate these discussions with their older patients. However, older adults have some of the same risk factors as younger people. So for example, there's a lack of knowledge about sexual risk. Sometimes there's another risk factor of having multiple sexual partners. And also sometimes older adults may be less likely to use a condom or pre-exposure prophylaxis or PrEP in terms of HIV prevention strategies. However, the research has shown that older adults are more likely than their younger counterparts to be diagnosed at a later stage during the course of HIV. And another issue that is very prevalent, especially for older adults, is stigma. So when we think about stigma, we wrote a review that was published in Current Epidemiology Reports that talked about double stigma, HIV and aging. And when we think about ageism, for example, as a form of stigma, and living with HIV as another form of potential stigma, these intersections will cause older adults to maybe less likely to disclose their HIV status. Older adults may also avoid getting care due to this double stigma, and this can result in more isolation and adverse health treatment, adverse HIV treatment outcomes. So let's switch gears a little bit and talk about trauma. So trauma is a huge factor, especially for people living with HIV. Research has shown that people living with HIV are more likely to be exposed to trauma than those who are not living with HIV. When we think about childhood sexual trauma or childhood sexual abuse or CSA, this is higher among people living with HIV. So people living with HIV tend to have higher prevalence estimates of childhood sexual trauma. When we look at sex disparities, women living with HIV are more likely than men to report experiencing trauma. And women living with HIV have been estimated to have rates of intimate partner violence, for example, at 55%, and childhood sexual trauma at close to 40%. And these estimates are more than double the US national prevalence. So trauma is a huge factor among people living with HIV that we have to consider as we think about psychosocial factors that may impact people living with HIV. And when we think about childhood sexual trauma, really, when we look at the literature, there is a lack of studies examining the perspectives of trauma, especially among older adults living with HIV, especially their history of childhood sexual trauma. However, studies that we have conducted have shown that childhood sexual trauma can continue to be a factor that affects older adults who are living with HIV. So, for example, a prevalence of 32% was found among older adults living with HIV, prevalence of childhood sexual abuse. Childhood sexual trauma was negatively related to antiretroviral therapy adherence. So, older adults who experienced childhood sexual trauma or reported a history of childhood sexual trauma were actually less likely to adhere to their antiretroviral therapy. And childhood sexual trauma has also been linked to substance use, psychological challenges such as depressive symptoms and post-traumatic stress symptoms, relationship challenges, self-blame, reliving childhood trauma, and as I mentioned, some older adults living with HIV report feeling the influence of childhood sexual abuse several years after the event. So this is a factor or an event that should not be forgotten, even for older adults who are living with HIV. And we also examined in another study the intervention program needs for childhood sexual abuse survivors. And when we examine these needs, three main themes emerged. This was a qualitative study that we conducted. So the program format and modality was an important theme for older adults living with HIV who have been exposed to childhood sexual trauma. Program content was also important in terms of addressing the childhood sexual traumatic events, and the program coordinator. So the person who would be in charge of coordinating this intervention. These were all important themes for older adults living with HIV. So most participants, based on our study, expressed a desire for a trauma-focused intervention program in which the CSA experience was addressed and they could talk to someone either individually, as a group, and sometimes both methods were preferred in terms of maybe first talking to someone individually and then talking to someone in a group-based setting. So some people preferred individually, some people preferred as a group, while some people preferred having both modalities. So when we think about substance use, so we know that, and the literature has shown us that substance use is an established risk factor for having an HIV diagnosis. And substance use disorders are prevalent among people living with HIV and can contribute to poor health outcomes, such as poor adherence to antiretroviral therapy, as was mentioned, poor viral suppression, poor engagement in HIV care. And most commonly used substances among people living with HIV include alcohol, tobacco, opioids, stimulants such as cocaine and methamphetamines, cannabinoids, benzodiazepines, and club drugs. So these are some of the most commonly used substances among people living with HIV. And substance use is also another challenge, public health challenge among older adults living with HIV. So older adults living with HIV have higher rates of substance use compared to older adults without HIV. And addressing the healthcare needs of older adults living with HIV who use substances can be a huge challenge, as older adults living with HIV are highly impacted by comorbid conditions, so other illnesses that they may have. Also, substance use can interact with other medications, including antiretroviral therapy. And as I mentioned before, substance use has been linked to reduced adherence to antiretroviral therapy and increased risky behaviors, even among older adults living with HIV. And the opioid epidemic is another huge public health challenge, especially in the US. And when we look at the opioid epidemic numbers, so for example, 10 million people misused prescription opioids in the past year. 1.6 million people had an opioid use disorder in the past year. 2 million people reported using methamphetamine in the past year, and 1.6 million people misused prescription pain relievers for the first time in the past year. So these are really staggering numbers, and it shows that the opioid epidemic is a huge challenge, especially in the US, and the opioid epidemic also impacts people who are living with HIV as well. So when we think about opioid use among people living with HIV, people living with HIV may have HIV-related pain and sometimes are commonly treated with opioids. People living with HIV may be at risk for negative outcomes from prolonged opioid use. And once again, when we think about the substance use disorders and their association with adverse HIV treatment outcomes, opioid use disorders may also result in delayed linkage to care, which we know is important for people who have been diagnosed with HIV. Delayed initiation of antiretroviral therapy or lack of adherence to antiretroviral therapy. And we know that these are very important in order to attain and maintain viral suppression, which we know is important in reducing the risk of transmitting HIV. So another factor that's very important is actually HIV-associated neurocognitive disorders. And these can also result from the inflammatory effects of opioid use. So when we think about HIV-associated neurocognitive disorders, these can include asymptomatic neurocognitive disorder, or looking at mild neurocognitive disorders, or even HIV-associated dementia. So these disorders can result from the inflammatory effects of opioid use, and these should be looked at when we're thinking about opioid use disorders, especially among people living with HIV. So the rationale for this study, when we think about the opioid epidemic, it's currently affecting many areas in the US. And there has been an increase in the opioid epidemic in the southern US, especially since the start of the COVID-19 pandemic. And when we think about childhood sexual trauma, this has been linked to substance use, but research focusing on specific substances are lacking. So what is the association between childhood sexual trauma and specific substances, such as opioids, for example? So we wanted to examine the relationship between childhood sexual abuse and opioid use among older adults living with HIV. And this was specific to the southern US in South Carolina. So what did we do? Our methods. So we collected data from approximately 91 older adults living with HIV, and they were all receiving care at a large immunology center in South Carolina. So because of the pandemic, we had started to collect data with online surveys, but actually, when we went into the clinic, we recognized that this population actually, there were a lot of people who preferred using the sort of the pencil and paper modality. So we collected data using online questionnaires and also using pencil and paper administration. So to be eligible, you had to be 50 years old or older, living with HIV, and we also assessed cognitive impairment. So you had to have a lack of severe cognitive impairment to be included in the study. So we also examined a few primary variables. So childhood sexual abuse was one of our primary variables. And the way we asked about childhood sexual trauma, we wanted to know before the age of 18, were you ever touched in an intimate or private part of your body that made you feel uncomfortable? Did you ever experience someone rubbing their genitals against you? Were you ever forced or coerced to touch another person in an intimate or private part of their body? Did anyone ever have genital sex with you against your will? Were you ever forced or coerced to perform oral sex against your will? Were you ever forced or coerced to kiss someone in a sexual rather than an affectionate way? So these questions really asked about childhood sexual trauma in a variety of ways. And then we looked at if the older adult living with HIV reported any form of childhood sexual abuse versus they did not report childhood sexual abuse. We also looked at opioid use, and we asked how often did the participants use opioids, and we gave examples: heroin, fentanyl, OxyContin, Vicodin, codeine, morphine. How often did they use opioids in the past year? And we asked never, once per month or less, 2 to 4 times per week, 4 or more times per week. And so we recoded this variable to whether the participant used opioids versus never used opioids in the past year. We also looked at sociodemographic confounders, so looking at specific variables that may alter the association between childhood sexual trauma and opioid use. So we adjusted for age, gender, we asked, we had male and female participants as well as transgender female participants. We asked about race, we had Black, white, and other participants, as well as we asked about education. And we also asked about other sociodemographic characteristics, but these were the confounders that we adjusted for in our final models. So for our analytic approach, we use descriptive statistics to describe the study population. We also obtained prevalence estimates of childhood sexual abuse and opioid use, and then we used multivariable logistic regression models to determine the association between CSA, childhood sexual abuse, and opioid use. And we adjusted for sociodemographic confounders, as I mentioned previously. So what did we find? So this table here shows the distribution of sociodemographic characteristics among older adults living with HIV. And we had majority were male. We had 2% of the study population reported being transgender female participants. Majority were between the ages of 50 and 64, and majority of participants identified as Black, and around 53% of participants reported to have at least some college educational attainment. We see that 67% reported being unemployed, and we see that close to 10% reported earning $500 or less per month. And we see that 20% reported earning greater than $2,000 per month. And then in terms of years since diagnosis, we see that around 5% were diagnosed within the past 5 years, but majority, 60%, had been living with HIV for over 20 years. So when we look at the prevalence of childhood sexual abuse, so the prevalence of childhood sexual abuse was 32%. So 32% of the study population reported that they were survivors of childhood sexual trauma. And when we look at the prevalence of opioid use, it was 10%. So 10% of the study population reported using opioids in the past year. And this table shows the association between childhood sexual abuse and opioid use among older adults living with HIV. So before adjusting for confounders, we found that those who reported CSA were 8 times more likely to report opioid use. And when we adjusted for the sociodemographic confounders, so age, gender, education, we found that those who reported childhood sexual abuse were actually 15 times more likely to report opioid use in the past year. So it is possible that the effects of childhood sexual trauma remains with some participants even as they age with HIV. So that's a potential explanation for what we are seeing here. So in terms of discussion and implications, so the primary findings are that 1 in 3 older adults living with HIV reported a history of childhood sexual trauma. And that's a lot. And 1 in 10 older adults living with HIV reported opioid use in the past year. And our study showed that childhood sexual abuse was associated with opioid use in the past year among older adults living with HIV. So the findings that we found in the study, these support previous studies linking childhood sexual abuse to substance use in adulthood. So some previous work that we did, previous research that we conducted showed that adverse childhood experiences, including childhood sexual abuse, were associated with substance use disorders. And these substance use disorders were linked to having an HIV or sexually transmitted infection diagnosis. So our results suggest that CSA, childhood sexual abuse, may have lingering effects among older adults living with HIV. Previous research has shown that childhood sexual trauma may have residual effects among older adults, and these residual effects may appear as depression and may appear as re-victimization. So when we think about the depression as a residual effect, it is possible that there is some trauma that has not been dealt with in a comprehensive manner, and this form of trauma can lead to depression even in older adulthood, can lead to substance use even in older adulthood. And this is something that we should recognize and try to come up with additional studies and research that will address these issues among older adults living with HIV. So we did have some limitations. So the sample size was relatively small. So we were able to collect data from around 91 older adults living with HIV. And another limitation is that all participants were receiving HIV care at an immunology clinic. And the findings here may not reflect relationships among older adults living with HIV who are not in care. So we really need to do more research on older adults living with HIV who might not be receiving antiretroviral therapy, who may be in isolation, who may be experiencing that double stigma that we talked about in terms of ageism and living with HIV and are not in care and are less likely to disclose their HIV status to whether it's healthcare providers, social support systems. So it's very important that we try to conduct studies and try to reach those populations that are not in care. Participants were living in South Carolina, and findings may not be generalizable to older adults living with HIV from other domestic regions in the US or even global regions. So when we think about older adults living with HIV, we see that approximately 8 in 10 older adults living with HIV are in low and middle income countries. So would we see these same associations among those older adults living with HIV? So there's definitely room for additional research, especially for older adults living with HIV in low and middle income countries, for example, and in other regions of the US as well. So there were some strengths of the study. So we had a diverse study population. So we had 68% Black participants, 30% white, and 1% identified as of another racial group. We had multivariable analyses that adjusted for potential sociodemographic confounders. And we mentioned the age, the education, gender, and so forth. And we were able to examine current opioid use. So opioid use within the past year. So this is not if they ever used opioids. This is opioid use within the past year among these older adults living with HIV. So in terms of implications and in concluding, trauma-informed interventions addressing childhood sexual trauma may be warranted even for older adults living with HIV. And these interventions, and even in the background section, I mentioned the importance of trauma-informed interventions, especially for older adults living with HIV who are survivors of childhood sexual trauma, and they highlighted that these were some of the important factors that they would consider in terms of attending an intervention program. So looking at the program coordinator, looking at the content of the intervention. Are you addressing the childhood sexual trauma event that occurred, even though it was several years ago? Is it still having an impact today? And also addressing the modality. So whether it's one-on-one, whether it's group-based, whether it's considering those two formats and doing sort of a bi-modality approach. So we see that trauma-informed intervention, specifically addressing childhood sexual trauma, may be warranted for older adults living with HIV. And this may help to attenuate or may help to decrease opioid use among this population, which we found was 10%. So 10% among this study population. Future research should determine the relationship between childhood sexual abuse and other specific substances. We saw that list of commonly used substances among people living with HIV, and those included alcohol, marijuana, tobacco use, and so forth, methamphetamines. So there is definitely room to examine the association between trauma, childhood sexual trauma, and these other specific substances to see if we see similar associations. And it's also important to examine the feasibility and acceptability of trauma-informed interventions among older adults living with HIV. How feasible is it for this population, and how acceptable are these interventions among this population? And also, it's very important to explore potential pathways between childhood sexual abuse and opioid use among older adults living with HIV. So what are important variables that may act as mediators, as these middle variables between childhood sexual abuse and opioid use? Is it depression, depressive symptoms? Is it other substances? Is it marijuana use? So these are very important to consider. So I would like to thank you so much for listening. I would like to thank the National Institute of Mental Health for funding this study through a K Award. I would also like to thank my graduate research assistants who have been instrumental in helping with data collection and analysis, Amandeep Kaur, Princely Osaado, and Titilayo James. And I can be found through email at brownm68@mailbox.sc.edu if there are questions. And I'm not sure if we'll be able to have questions now, but if you'd like to get in contact with me to know more about the research study and so forth, I can be reached through email at brownm68@mailbox.sc.edu. And that's it. Thank you so much.
Thank you, Dr. Brown. I really appreciate it and appreciate you being with us on a Saturday. Does anyone have any questions about the presentation? Any questions about the research in general? No? I think everybody's a bit fried at the end. We do have one question. Here we go.
Okay.
Thank you very much for the presentation. My name is Gary. I'm from London. It's always of interest to me to look at where we're at as people living with HIV currently, and also then to think about where we've come from with that. And I guess one of the questions, it comes up to me every time we talk about mental health and people with HIV. So we're more likely to experience depression or other mental health issues.
Right.
I always ask myself, well, is it because we're more likely because of HIV, or are we more likely to have contracted HIV as a result of those mental health issues, the chicken or an egg situation? And I guess looking at this from where you're at now, looking at this snapshot of where people are, was there any then additional questions to look at whether there was previous drug use, not necessarily just opioids, but any drug use historically before diagnosis? Because I think for me, it's that connection that is the drug use now something that relates to living older, living with HIV, the different issues and challenges that come up there? Or is that also linked back to past drug and alcohol use or misuse that may have then resulted in that diagnosis? And so it's about picking apart some of that. So was there anything within the data that looked back at prior use at pre-diagnosis, for example?
Yes, that's a great question. We did not collect data on substance use before HIV diagnosis. So we did not collect data on that, but that is an excellent point, because when it's very important. Sometimes even, some of the questions that I get also is that, for example, when we look at people who are survivors of sexual trauma, that may lead to depression and sometimes, and that may lead to substance use. And some of the questions that I get are, does this mean that the childhood sexual trauma was a factor in attaining an HIV diagnosis? And sometimes, most of the times, based on the experience with the study population that we have, is that sometimes that's not necessarily the case. We just had maybe a few people who felt that they were at risk for HIV because they were involved in sex work. They were sex workers, and they attributed going into sex work because of their the trauma that they had. But that was not the common situation for this population. So that was maybe a couple of people who experienced that. So it's very important, and I think that your question has raised a very important factor that I will consider in terms of looking at substance use before HIV diagnosis. And because we know that substance use is an established risk factor for HIV diagnosis, whether it's injection drug use and using contaminated needles, or whether it's while you're using substances, taking part in risky behaviors, or not being able to use condoms, or not being able to negotiate condom use properly during that instance. So I think it's very important. So unfortunately, we did not ask that question, but it's something that I will consider for future studies.
Thanks so much, Dr. Brown. Any other questions? All right. Thank you so much for being here with us. We really appreciate it.
Okay. Thank you so much, Kate.
Have a great rest of your weekend.
Thank you. You too.
Bye.
Bye.